but I'm here today to talk to you a bit about the illness, a bit more information about the illness. And initially I thought, well, what do we talk about? You know, you never kind of know, because the whole area of management of this illness is growing and growing and growing, and you know, you could spend a whole session on one little snippet. But I thought the best thing to do would be to do what I did to the Auckland group quite recently, which was to talk about where we're at with the research, and just make sure I get that moving on right. Yep. So you know, everything in the last year, if not more, has been dominated obviously by the COVID situation. And the good news is, of course, it's going to pour enormous amounts of research money into chronic fatigue syndrome, ME. You know, whether you say that's good or bad from the point of view of all the poor people who are suffering illness is a bit of a moot point. But I think, you know, we can only say that, for example, in America, the government have put in $1.1 billion for research for the so-called long COVID. And of course it is the same illness, really, we can't deny that. The same illness, but with a little bit of a sideways difference, just the same as many, many people in this room probably have quite different illnesses to each other. So we're looking at a sort of umbrella term, well, let's call it chronic fatigue syndrome. And that encompasses lots of subcategories, of which the long COVID is one of them. And some of the people who have chronic fatigue syndrome will have started with a typical viral illness. Others, it may have started with an accident or an immunisation or something like that. But, you know, they've got these subgroups, really. But the long haul thing is really the same thing. And, I mean, Dr. Mady Hornig, who you see the name up there, she's a leading CFS researcher, and she has actually succumbed, unfortunately, to the long COVID. There's a website, which, I mean, don't even try and write it down, you'll be writing forever. But I'm sure the slides will be available via the Tracy afterwards if you need these details. But it's a very, very interesting interview between her and some interviewer. And that would be worthwhile watching. But anyway, money's going to pour in, we hope. And that's just a few of the bits and pieces of money that's already been, in the last few months, been poured into research. And Professor Tate down in Dunedin, who some of you will have perhaps heard speak or read some things about him. He's a leading biochemist in New Zealand and internationally very, very well recognised. He actually won the Rutherford Medal, which is New Zealand's highest scientific award. And he has done some really, really good work looking at the genetics and the underlying chemistry of chronic fatigue syndrome. He's had a couple of papers published very recently which have been internationally acclaimed very widely, and he's now doing a study comparing people with chronic fatigue syndrome, the traditional illness, like most of you here will be suffering from, comparing it with the long-haul COVID patients that we've gathered here in New Zealand and comparing it with healthy controls. So this will be a very, very valuable study, and I think again, because his work is so well received internationally, it will spread around the globe. And of course, the more research that's done, the more government and organisations and bequests and everything else pour into research, and the more research that's occurring, the better your chances of making progress in the long term. So anyway, going backwards nearly a year now, I went to a conference, the International Association for Chronic Fatigue Syndrome, based in New York, and you might think, well, how did she get to New York in August? Well, she got to New York overnight in her lounge, cuddled up by the fire. So it was a Zoom conference, and my daughter, Dr. Sarah Dial, who's in Rotorua, She and I attended that conference. It was great, actually. It wasn't quite the same, of course, as being there, but it was a great experience, and we both between us have written a report, and again there's a website there, but I'll just run through some of the interesting stuff with you. So there was a whole segment inevitably on COVID. That was at that stage only, 6-8 months down the track, but already people were focusing on this as being very much the same as chronic fatigue syndrome. And there was presentations from all over the globe, including the Japanese, who said that one of the reasons, of course, people get so frustrated, why isn't the research going into treatment? I mean, again, they emphasized with a lot of illustrations really the importance of understanding the underlying immunology and chemistry and all the other stuff that's going on before we can even begin to find treatments that are reliable. I won't go into a lot of detail with all this stuff because we've probably got lots of things to cover and we can have some question time at the end. But certainly it seemed that visiting housebound patients was enormously beneficial, and certainly in America and in Europe they are now training people who can go out and see people with this illness who are housebound, the people who obviously can't be here today. There's also a lot of talk about low-dose naltrexone, and I've been sort of bombarded with people really over the last 6 months wanting to try this medication. And low-dose naltrexone it's got some good reason to use it. And what it is, it's a drug it's very old-fashioned drug, used in very large quantities, or normal quantities I suppose we could say, to help people come off drugs like heroin and morphine. So it's a kind of benefit for those people. It helps get them on the straight and narrow again, and it's been used for a long time for that. But they found, a group of rheumatologists did some research probably about 8 years ago now, and found that low doses of this drug, very tiny doses, and we're talking 1 to 2 milligram, and as I say they're up to about 4.5 milligram, as opposed to 50 or 100 milligram for the addict treatment. They found that these very low doses were particularly helpful for the fibromyalgia aspect of the pain. So that really has been used quite a bit, this low-dose naltrexone, since that study in people with fibromyalgia, and it's extended to people with chronic fatigue syndrome, and we can talk a little bit more about how it works. Another presentation was the importance of what we call oral rehydration, and this is people who've got POTS, orthostatic intolerance is its other name, but for you the common symptom that's associated with that will be feeling rather woozy and lightheaded if you stand up suddenly or when you first get up in the morning. And this is due to almost like the oxygen and fluid to your brain sort of falls into your feet as you stand up suddenly, and it takes a little while for your system to kind of recompensate, and it's thought a lot of it is due to the lower blood volume. You haven't got quite as much volume circulating in the way of blood in your system, and they've certainly proven now that one of the best forms of treatment is to rehydrate yourself very regularly, keeping up your fluid balance, but it's more importantly to be adding plenty of salt to the fluid, either salty water or electrolyte drinks, or just salt, salt on your crackers or your snacks or what have you. And I usually tell people, have a salt fix every couple of hours, and it can be very helpful. But the particular people doing the presentation at this conference did say that one of the most important things was to have glucose as well, because glucose gives you energy. It doesn't have to be as glucose. You don't have to go out and buy some glucose specially. Anything sweet really, because anything sugary is going to turn, your body will turn it into glucose, which is what's required. So your brain needs salt and glucose to function properly, and it needs the extra fluid to pump it round your system. And we do often use medication now to improve the retention of the salt, called Florinef. So we'll see. And then talk quite a lot about diagnosis. I mean, I'm just picking out a few things here because we could go on and on and on. And the conference lasted, I don't know, 16 hours, and so I can only give you snippets in this short time now. But they have shown that, yes, for that orthostatic intolerance, so-called tilt table testing is quite important. And people often ask me, you know, where can I go? Where can I get a tilt table test? Because this proves that you've got it, and that then makes the prescription of treatment far more likely to help you. So Dr. Bateman in Utah, she has devised a form, because tilt tables kind of expensive and difficult, and only cardiologists here and there have a tilt table, so it's not easy. But she has devised a very simple sort of tilt table, and I won't even go into it because I might fall on the ground or something, but you lay back against the wall at a bit of an angle, kind of supported so you don't fall to the ground, and then you sort of, you know, change your position, and they do various measures of your blood pressure and things like that. But it's a kind of simple test that means you get proof that yes, you've got this orthostatic intolerance, which is one of the common symptoms of chronic fatigue syndrome, and therefore the treatment that I've just mentioned, or possibly the medication to help your body retain the salt, becomes far more likely to help you work. I'm not going to go into a lot of detail about the next bit, because I think probably most of you have read quite a lot and know already, but they have found that the biochemistry of the body in this illness, and various studies now have shown this, all your chemistry is all out of kilter. And they measured, this particular study, 600 odd chemicals in your blood, and there are many more than that of course, but they measured 600 or so and found that 159 were abnormal. And these abnormal, you know, kind of chemical imbalances, if you like, were very similar to what they find in animals who are hibernating. So it's almost like people with chronic fatigue syndrome are in a state of hibernation. They call it DAUER, D-A-U-E-R, and that is the sort of technical term for hibernation, but they found it quite consistently. So that's very, very interesting, really. They also found that healthy muscle cells, you know, they kind of take samples from people, and they get sort of a sample of some healthy muscle cells and put them into the serum of people with chronic fatigue syndrome, not into their body, but in the laboratory. So you might have a Petri dish with some ME-CFS serum, and that is the watery content of your blood as opposed to the blood cells. So you get the serum in a dish, add in some healthy cells, and the healthy cells behave quite abnormally, and they produce much more of the so-called lactic acid. So this helps to explain why people get a lot more pain in people with this chronic fatigue syndrome, get a lot more pain in their muscles. Then we move on a little bit. I've left that conference now, and I'm moving on to what's going to be happening here. Again, I say here in London in May of this year. They have a conference, or sort of conference, in London every year called a colloquium, and you have to be invited to go. It's not a something that anybody can sign up for. So I've been now for about 10 times annually, and usually there will be about 200 people, some of them clinicians like myself, and some of them will be researchers and so on, from all around the world, and normally gathering in London and spending about 4 or 5 days of intensive lectures, discussions, and obviously interaction, which is important too. And this last year, of course, it had to be cancelled because of COVID, and it was all around the time when nobody knew what was happening, so they just cancelled it and be done with it. We didn't have it. But it's going to be happening in May 2021, it says there, but actually it's June. It's all not quite May. I think it's going to be in about 10 days' time, the first few days of June. And again, it's going to be Zoomed online, and they will produce sort of handouts afterwards about the up-to-date research, and these will be some of the top researchers around the world. And again, that website, if you keep following it, will bring you up to date with what's going on. In the UK, there was quite a lot of research been going on, and I mean, certainly they say it's definitely a multi-system illness, and we're talking, what do we call it? Chronic fatigue syndrome, ME, fibromyalgia, POTS. It's basically all the same thing with some variations, but they have identified the genes that lead into these conditions. So you're not born with the illness, but you're born with a genetic predisposition to it. So you are a little bit vulnerable through your earlier life, and then something happens to you at some point in time, and that vulnerability surfaces, and bang, you've got the illness. There would have been a lot of systems of the body is affected by the illness, and I've got a list there of the blood and plasma, the heart and cardiovascular system, the immune system, grossly dysfunctional, metabolomics, which is the body chemistry, which I just talked about just now, the microbiome, which is all the bugs and bacteria in your bowels and gastrointestinal tract, the mitochondria, which are the little powerhouses in your muscle cells, and the neurological system. So many systems affected, and for some people, one or other of those symptoms will perhaps be more prominent than another. So someone might have all trouble with their gut, and another might have a lot of neurological symptoms. So it's very variable, but a lot of illnesses are like that. The Australian research is very, very exciting, and I've probably told you a little bit about this before, and I wouldn't expect you to even begin to understand what's written there, because I can barely grasp it myself. In fact, what is quite interesting, that Australian team, I know them very well. They're in Queensland, Griffith University, and one of them asked me to read his paper before he sent it into publication to make sure I thought it was accurate. Well, it was like reading a foreign language. I had no idea what it was about at all, but I sent it back and said, oh, it's very impressive. But anyway, it was impressive in that it knocked me sideways. But anyway, they've found various things in the blood system which are quite unique. And I mean, I'm only saying this a bit off the top of my head, but I think they will eventually come up with a blood test that proves whether or not one has got the illness, and that will be hugely beneficial. Probably still quite a little way off, but their research is closer probably than many others to that. And what basically the sort of crux of this stuff there is that every cell in your body uses calcium. and calcium has to move in and out of every cell of your body, and it's doing it all the time. And it doesn't matter how much or little calcium you have, your body tries to keep the balance corrected. And it uses this thing called TRPM3, which is a kind of, it's called a receptor. It helps the calcium, or it encourages the calcium to move in and out of the cells and keep things nicely balanced so that all the cells work properly. And what they have found is that in people with chronic fatigue syndrome, and they've looked at large numbers now, that mechanism is very much at fault. So the way calcium moves in and out of cells is just not functioning normally. They've tried various drugs and they're still ongoing. I mean, this research is exciting and still going on, but they have shown that the low-dose naltrexone, the LDN at the bottom there, which is what I mentioned a little earlier on, is actually quite beneficial to this particular mechanism. So the LDN's being found to do various things. It certainly does help with pain for some people and even sleep for some people. It's not the kind of panacea for everybody, and it's not like a magic thing. There's a lot of luck in it, and some people only get mini benefits as opposed to a bigger benefit. But it certainly helps pain and sleep. It helps this mechanism, and that's maybe how it helps pain and sleep. And it also quietens down what we call the microglial activity in the brain. The brain is shown in this illness when you have a brain scan, a very specialized type of brain scan, shown to have a lot of cells that are sort of sparkling and active, and these are called microglia, and they are cells which are very inflamed in the brain, and this may be why a lot of people get things like brain fog and headaches. The brain is, very compromised, and the low-dose naltrexone has been shown to suppress the hyperactivity of these microglia. So, the more they look at it, the more useful it seems to be. Okay, I've mentioned Professor Tate and his research into what we call epigenetics, and epigenetics is a step beyond genetics. Genetics is the study of how the genes work and what's going on in our bodies and what we inherit and all the rest of it. Epigenetics is the way the genes actually work, and Professor Tate and his team in Dunedin are doing this peripheral blood mononuclear cells work, very, very important work. And then the second paper there, and those two papers have been really widely acclaimed internationally. I'll give you a list there of some of the potential medications that are being researched, and again, I haven't got time today to go into them all in detail, but just to run through a little bit. Certainly we use hormones for sometimes women need estrogen. Fludrocortisone is the drug that helps your body retain salt, and some people do quite well on the drug called prednisone. A lot of psychological medications are used for various reasons. If people are depressed or having psychological issues with anxiety or psychological diseases, all these things are going to drag them down further if they've got chronic fatigue syndrome. So we need to acknowledge these things and deal with them, and not be saying, oh, your illness is all in your head. We're saying if we treat what's going on in your head, you may well be a lot more able to handle this illness, or you may get a lot better. So we shouldn't deny psychological intervention. A lot of the researchers will say until you treat things like depression, you haven't got a show of helping the person get on top of their CFS, because depression and stress drag down absolutely every illness in the book. Anti-epileptic medication is used quite a bit for pain relief. Pregabalin, clonazepam, gabapentin, they're all quite powerful drugs, but certainly when people have bad pain, we have to, focus on what might help. Then we've got drugs that help the cardiovascular system, quieten down anxiety, but also improve brain blood flow. The one nimodipine particularly improves brain blood flow so people can think more clearly. I've mentioned the low-dose naltrexone. Some of the drugs used in neurology to treat various neurological diseases can be helpful. And sleep medication is very, very important. Everyone with this illness needs to get a good sleep. Everyone needs to get a good sleep, not even ill people, because it's the time of your 24-hour clock when your body produces all the hormones and chemicals that have a really good healing effect on your body. And if you're not getting that deep level 4 sleep for several phases during the night, you go down into deep level 4 phases, that's the healing time, and if you're not getting that, you're not going to get better. And many people will say to me things like, well, I've slept for 12 hours, I'm still not refreshed. They haven't had that deep level 4 sleep. They've been sort of theoretically asleep, but not actually getting benefit from their sleep. So the aim is to get people into a restorative, refreshing sleep of about, between 7 and 10 hours ideally. And often medication will be needed to that. And the ones that we use most commonly will be those 3 I've got mentioned there. Melatonin, which is good for body clock control. The low-dose tricyclics such as amitriptyline or nortriptyline, which gives you back your quality sleep, your deep level 4 quality sleep. Promethazine, which is an antihistamine called Phenergan commonly, if you've got a lot of problems with the runny, blocked up nose. So sleep work is very, very important. Sometimes muscle relaxings will help because if you're very tense or your muscles are painful, something helps them relax, you're more likely to sleep more restoratively. Antivirals are used by some clinicians, again, if we suspect that there's still some viral activity lurking. And the typical group of viruses that lurk will be the herpes group of virus, and that includes things like shingles, chickenpox, genital herpes, cold sores around the mouth, and so on. And those viruses lurk and linger for a very long time, and they can keep you at a low ebb of health. And so dealing with those with antiviral agents can be very, very worthwhile. And Dan Peterson, who's a well-known researcher in the States, he's done a lot of work with a drug called spironolactone, which is not an antiviral at all normally. It's used to treat fluid retention in general medicine, but he found that it's got very powerful antiviral properties, and for some people it's a better bet than going on to antiviral medication, which might have a lot of side effects. So, there are options coming up out of the blue all the time, really. Cyclophosphamide is a cancer drug, anti-cancer drug, and there's a lot more research now going on looking at some of the anti-cancer drugs, that one in particular being looked into in Norway, because they have actually had some good results in the past from anti-cancer medication. And so, the studies are going on, but we have to wait for these studies to be done rather than rushing in and saying, well, let's try this, let's try that, because sometimes these medications can be, downright dangerous. So you have to be very aware of that. And then there are drugs that suppress the very overactive immune system, because this is an illness whereby the immune system is very hyped up and very overactive. And one in particular, isoprinosine, is actually available here at great expense, but that does suppress the immune system, and some people have done reasonably well on it. It's unfortunate that it doesn't really give you much benefit till you've been on it about 6 months, and it's got some side effects, but it's very expensive. So, it's a bit of a dilemma as to whether one's going to try it. And I think the research that's been done has shown that only 1 in 4 people actually do benefit. So, don't rush into that one. The interesting one at the bottom is Suriname, which is a drug very, very old-fashioned, used to treat sleeping sickness in Africa. And Ron Davis, who's one of the ME World's leading researchers, thought, well, here we have a drug that was used to treat sleeping sickness, and here we have all these people who are not exactly sleepy but terribly tired. Maybe that drug could be of benefit. However, it's no longer available. It's been superseded by other more modern stuff, and he is trying to get it remanufactured so that it could be trialled for people with this kind of illness. Leptin is an interesting issue. Leptin is a body chemical that we all produce, and if you produce too much of it, you tend to find that these microglia in the brain are very much more sort of active, and more headaches and more of those kind of symptoms. And when you are producing a lot of leptin, which you probably are in chronic fatigue syndrome according to these studies, you tend to feel more hungry, and you find that you want to eat more, and you find you put on weight more readily. So, you know, there's been a lot of work to try and find ways of decreasing leptin levels, and weight loss is one of the surest ways of decreasing leptin levels, because leptin is produced from fat cells. So leptin, you know, kind of is produced by fat cells but makes you feel more hungry, so you get fatter. So, you know, it's a very important study, and certainly by getting the leptin levels down, your microglial activity in the brain can improve. They're also trying out various other drugs as well. So what have we got? We've got 72 years of research now, from probably more than that actually, but 72 years of active research that's been published in medical journals. And there have been many, many theories and treatments tried, lots of sophisticated lab work, but it's kind of moved on and on and on and on to become now very much recognized as a multi-system illness with lots of subcategories, some treatments which work for some people, some don't. The commonest and most important symptom really is what we call post-exertional malaise, PEM, and the probably vast majority of people in this room will know what I mean by that. It's the effects of exercise, the effect of pushing exercise beyond your comfort zone with this illness. So in other words, you might have previously been quite athletic or active, but now you might find even just walking out to your car completely zonks you out, or certainly trying to go for a longish walk, or play a sport, or clean the house, or for some people just a very minimal amount of activity, get this so-called post-exertional malaise. And it's not just tiredness. The muscles become really weakened and exhausted, and you actually can feel quite ill with it. So it's recognized as a kind of constellation of symptoms, but is very, very typical of this illness, and is rarely seen in many other illnesses. So, you know, it can be the deciding factor when one's trying to make a diagnosis. You've got all these many symptoms, but if the person's got this so-called post-exertional malaise, and it's more than malaise, as I'm sure many of you know, but the characteristic is it's often delayed. So you might be absolutely fine while you're doing the exercise or the activity, but the next day you can barely get out of the bed. So it's a very, very important set of symptoms that helps to make a diagnosis. Okay, well, we'll move on, changing the subject, because we can have some questions afterwards, I'm sure. But people, or Tracy and various people, said we should talk a little bit about the COVID vaccination and what we should be doing or recommending to people with this illness. And we know that COVID-19 is a very, very serious illness potentially. And just because you've got this illness, now chronic fatigue syndrome, it doesn't mean you won't get COVID. A lot of people with chronic fatigue syndrome have said things to me like, oh, I knew I was getting a bit better because I started to pick up bugs again. I started to get colds again. So they started to get ordinary colds and flu. So people with this illness, this chronic fatigue syndrome, have a very overactive immune system a lot of the time, which protects them against bugs, say like COVID or chickenpox or anything else, flu, colds. But you know, that varies from month to month, day to day sometimes, and certainly if they're beginning to improve a little bit from where they might have been way back. So you can still get COVID-19 even though you might be a little bit self-protected. The vaccine itself is not a live vaccine, so the risk of ill effects from it are quite small. Some vaccines which, you know, people have had bad reactions to in the past is because it has been a live vaccine or something about that vaccine which has been particularly kind of potent in some way, so they've had a bad reaction to it. But I think the other thing to say about the COVID-19 is if you happen to get the illness, it may make your underlying chronic fatigue syndrome considerably worse, and I'm sure you don't want that. So ideally, one would be recommending that yes, you should have it, the vaccine, and you should choose a time. I mean, you may not get much choice yet, but later on I think there will be choice. Choosing a time when you're sort of slightly at your best. In other words, you don't want to go when you're going through a bad relapse, because it's going to be harder to sort of get out there and go and get it, but also should you have anything in the way of a reaction, and even the most healthy people like me can have a reaction, it's better to be at a time when your body's more able to handle it. So you choose a time when you're sort of at your best, if you have a best, and before the vaccination, rest up a bit. So you're not pushing yourself hard and thinking, oh, I'm going to have my vaccination tomorrow, I better clean the house today in case I have a reaction. It's about the worst thing you could do. Think, I'm going to have my vaccination tomorrow or the next day. I'm just going to lie around and read my book and do very little for a day or two. In other words, I'll set the scene. And then after the vaccination, you might well have a bit of a reaction, because even the most healthy people do. They're usually very mild flu-like symptoms, a sort of vague achiness or a vague headache or a very minor fever, usually very, very mild reaction. I've had this vaccination, I didn't have any reaction at all, so, you know, think lucky, but there's no reason to suppose you will have a reaction, but be prepared for the possibility, and again, allow a day or two after to, you know, have recovery. In other words, don't set yourself up to do a whole lot of other stuff. Also, they say people who've had reactions to vaccinations or medication, or they've got an illness like this where they're a little bit more sensitive to things, it's quite a good idea to go prepared and take either some paracetamol with you, antihistamine like loratadine, just a simple antihistamine, or if you've had bad reactions to things, some prednisone. Now, your doctor can prescribe these things for you, or apart from the prednisone, you can just buy them over the counter, but you know, you're kind of prepared then, and if you really want to, you take the paracetamol and the antihistamine beforehand anyway, or at least have it at home. And also, after you've had your vaccination, they always want you to hang around, as same with a flu injection, you hang around for 20 minutes or so to make sure you're okay before you're released. With this illness that you've got, it might be worth staying around a little bit longer, up to an hour, take a book with you, or something, you know, some music that you can listen to on your phone or something, and be prepared to stay for an hour to make sure not because you're particularly likely to have a reaction, but to give yourself confidence that if you've got to go out and drive home, you're not going to be sitting there waiting for something to happen, you know. Better to stay at the facility, which is, you know, either a doctor's surgery or one of these vaccine centres. I went to the place in Mount Wellington, the middle of Auckland factory area, very busy, but, you know, there were really nice, comfortable rooms to sit around in afterwards. It was all very, very efficiently set up. So, you know, I don't think you need look on it as a fearful thing, but something to be aware of and to be prepared for. We know that certain people are much more at risk of getting this illness, certainly over 65-year-olds. People who've got underlying illnesses like asthma or heart trouble, lung disease and so on, and immune deficiency. But of course people with chronic fatigue syndrome generally have a very overactive immune system, the opposite of an immune deficiency. So, you know, you weigh up the pros and cons. You may not get 100% immunity from it, we just don't know yet. You know, it's not been around long enough, and we don't know how long it'll last. I mean, it may last 5 years, it may last 6 months, we just don't know. And for most of the vaccines, there's going to be a booster second dose, and the one for the Pfizer one that we're using here, you have to have your second dose 2 to 3 weeks after the first. So, you know, kind of be prepared for all that kind of thing. And not to forget the obvious, which we've all been a little bit brainwashed about, but on the other hand, almost getting to forget because, you know, we're not, as a country, we're not very exposed to it very much, so we tend to forget about the intensive hand washing, and, you know, nobody's here wearing a face mask, and I wouldn't expect you to be, but I mean, that's the sort of thing we need to be very aware of should there be more cases and so on, and using the Tracer app when you go around if you've got the phone, and remember to use it and so on. Oh well, that's the book that they mention. I've got a couple of books here that I've written. That's something, you know, you can, there's a flyer if anyone wants it. But we've probably now got time for some questions, haven't we? And I won't promise to answer your questions, but I'll have a go. Libby.
Do you know the Australians in terms of the naltrexone and the PRMP? I know that they're recruiting patients for a low-dose trial. Do you know if in the laboratory, if they took any particular dose of naltrexone and dose, or did they just sort of douse these things?
Well, Libby here has asked about the low-dose naltrexone trial in Australia and whether they, you know, what's going on there and whether they took random doses or big doses or little doses. I don't honestly know the detail, except to know that the whole idea of using this medication is that they would use very low dose form because two reasons for low dose form. First of all, they've shown that the low dose form works, and they've shown that people with this illness are very sensitive to medication. And just to give you a little bit of my own experience, I don't know how many people I've given low-dose naltrexone to now, but quite a lot. And my feeling is I haven't kept long-term follow-up because it's almost impossible to do that. But about a third of the people will say, well, it did nothing for me, even when you put the dose up a bit, you know, so you kind of try titrating the dose up a little bit. So let's say about a third will get no benefit, about a third will get unpleasant side effects, and those side effects can be certainly insomnia, feeling kind of ill, not feeling at all energetic, you know, feeling more limp and lethargic. So we got 1/3 no benefit, 1/3 side effects, and about 1/3 who get some benefit. And we start them usually with 1 milligram a day and then put it up by 1 or 1.5 milligram to about 4.5 milligram. So it's a very, very tiny dose. But even at that very tiny dose, some people do get quite nasty side effects. You have to be prepared for that. The other thing is expensive. It's not cheap. It's not funded by Pharmac. The prescription has to go through to a special place where it's made up, and it costs about $120 a month. So, you know, for some people that's very, very hard going. You can, if you're on some sort of benefit, get some help sometimes from with your disability allowance towards it, depending on how much you're already getting for other things. But, you know, it's not sort of something, oh, I'll just pop along to the doctor and get a prescription. It's kind of quite a complicated procedure, and you have to be prepared for it not working for you. And some people will say it doesn't start to work, they've been on it about 3 months. So again, you're looking at $300 or $400 before you might by then think, I spent all that money, I've got no benefits. So, you know, we don't rush in and say, well, this is the panacea for all ills, because it isn't. Okay, yeah, well.
Have you used aripiprazole with any patients?
Aripiprazole, yeah. Okay, this lady, if I've asked if I've used aripiprazole, the answer, first of all, is to say no, but it doesn't mean to say I'm not going to use it. Aripiprazole is a very potent antipsychotic medication, so it's used for people with quite serious psychological illnesses, usually by the psychiatrist. And it's again got quite a lot of side effects. It has been shown in some studies now to potentially have some benefit for people with chronic fatigue syndrome. They're not exactly sure of the mechanism, but there has been some studies that showed, yes, there could be some benefit. I've been a little bit loath to prescribe it because I still feel it's very much in the realm of the psychiatrist who understands this drug, and does a good job of, you know, monitoring people with it. So I say to people, if you want to try aripiprazole, that's your choice, but we have to refer you to a psychiatrist to get it properly dealt with and monitored.
Even if it's the low dose?
Even at the low dose, yeah. Mm-hmm. Okay, any more questions? Yeah.
So is the PACE study in the UK on its last legs now? With the,
Sorry, I couldn't quite, whoops, 1 minute, I've got all this bits and pieces. What was all that?
Is the PACE study in the UK?
Oh, the PACE study.
Yeah. Is it on its last legs now?
Well, that's a good way of putting it, isn't it? He's asked if the so-called PACE study in the UK is on its last legs. Well, the PACE study, of course, was in, you know, kind of encouraging paced type or ongoing exercise, graded exercise and this kind of thing. They've now come up in the UK with the so-called NICE guidelines, N-I-C-E, I can never remember what those 4 letters stand for, but anyway, the NICE guidelines will be published in about a month, I think, or 2 months. July is the latest likely time it's going to be published, and this is going to be a much more straightforward, down-to-earth management plan which matches the research internationally for people with chronic fatigue syndrome. And I think it's going to make a huge difference in Britain, because for years, and not just in Britain but all over the place, you know, there's been a pressure for cognitive behavioural therapy and graded exercise therapy. Well, cognitive behavioural therapy is all right. That's just a sort of counselling technique which probably every single one of us in this room could benefit from. It helps us sort of, you know, organise our lives and be stress-free and learn some relaxation skills and so on. So that's okay, but it's the graded exercise which has been found to be so damaging, even when in a very paced approach, very damaging for people with this illness, creating risk of major relapse sometimes. Okay, any other questions? Yeah, can you shout out?
Yeah, I'm just curious, I've been getting like violent leg kicks when I lay down to go to sleep, and yeah.
Restless legs?
Yeah,
in bed?
Kick out.
Yeah,
I just wondering what might cause it.
Okay, well, you know, we call what this man has just asked about restless leg syndrome, which can be quite sort of, as you say, violent. You know, your legs can kick around. Some people, it's just little mini movements. They can't keep still, you know, drive their partner around the bend probably. But restless legs of one degree or another, even crampiness of the legs, so they go into intense spasm, is very common in this illness for people, you know, when they go to bed at night. Not just in this illness, it's a symptom that occurs in a lot of illnesses, but there are medications that can be given to alleviate that. Various types of muscle relaxant and so on. So it is worth treating because it can make it very difficult to get to sleep sometimes, and of course we really want to promote really good sleep. Okay, so you know, dealing with that, talking to your GP, there's a lot of options there.
Hi, have you trialed or has anybody done any work with cannabis oil?
Sorry, I couldn't hear that.
Sorry, has anybody done any work with cannabis oil?
Oh, cannabis oil, right. Has anyone done any work with cannabis oil? Well, cannabis oil is kind of a bit of a buzzword these days, I think. And studies will be in the pipeline going on. I'm absolutely sure of that, because it's internationally talked about quite a lot. But of course you can buy cannabis oil here now or get cannabis prescribed. There are a number of doctors around who kind of specialise in this area, and I think if you were wanting to use cannabis oil, then it would be worthwhile going to see one of those people, because your dosage needs to be very carefully worked out and titrated. But some people have reported to me that they've done very well on cannabis oil for sleep particularly. Again, it's very expensive, so it's not for everybody. But I don't think there's any major risk or serious harm from it. You know, it's certainly, and studies will be forthcoming, I'm absolutely sure of that. This conference that I'm going to be attending in, I don't know, a week's time or whenever, in London, online, I'm sure they will be talking about it then, so I'll be able to write that up and get that distributed around. Okay, I think the expense is what holds most people back.
The long COVID, do they have a man now that they're part of us? The management plan is the same as that?
Yeah. Okay, this lady asked about the long COVID, and now it's been sort of recognised as part of the same umbrella, whether the management plan would be much the same. And yes, it would. The patients I've seen with long COVID, I think I've seen 5 now, have all had a very similar kind of illness to what most of you will have experienced, in that probably some sort of, you know, viral onset, flu-like symptoms, then really getting quite bad, and then the symptoms persisting and not going away. Again, we find with chronic fatigue syndrome, and I think long COVID will turn out to be the same, that the symptoms often mimic the original illness. So if, for example, your chronic fatigue syndrome started with gastrointestinal infection, maybe you get lots more gut problems with diarrhea and nausea and stomach upsets with certain foods and so on. Whereas if your illness started with a really bad cold and flu, many of your ongoing symptoms may be sore throats and glands up and so on. And I think what we're finding with the long COVID reports I've read is that if you were one of these people that was hospitalised with a lot of respiratory symptoms, then your ongoing symptoms may well be lung related. So, you know, you get the kind of prominent symptoms that relate to the original illness, but then associated with all that, the overall general fatigue and difficulty in sleeping and, you know, lots of aches and pains and so on and so on. So the illness is very much mimicking probably the original illness, but also with the added extreme fatigue and post-exertional malaise and so on. Interesting, the patients I've seen with the long COVID have been youngish, 30, 35-ish, people who haven't had a particularly severe illness. They've been maybe a nasty feeling of a flu-like illness, but not hospitalised or having, a lot of lung problems or needing oxygen or anything like that. So a mildish illness compared with those, but also in the younger age group. I mean, that doesn't mean to say there won't be older people out there who get long COVID, or people out there who are older who get a very severe long COVID. We just still don't have enough numbers. But I know Professor Tate is gathering numbers, and over time his studies will be revealing. He's looking particularly at the underlying body chemistry and the so-called epigenetics associated with the long COVID compared with the chronic fatigue people. And he may well find out that they're exactly the same. On the other hand, they may be very different. Okay? And yeah.
When you've got someone with chronic fatigue and then you add in a head injury, are you then more likely to have neurological problems long term?
Sorry, if you're...
Chronic fatigue and then a head injury.
Oh, head injury, right, yeah.
So
More likely to have neurological symptoms.
Yeah, will one make the other one more predominant?
Okay, well this lady, those of you at the back won't be hearing, she's asked me if your chronic fatigue syndrome started with a head injury.
No, I've already had chronic fatigue, then gets head injury.
Oh, right. Well, we can look at it both ways round then. So, okay, she already has chronic fatigue syndrome, then gets a head injury, and I would say it could be the other way round. But, certainly if you've got chronic fatigue syndrome and you've got a head injury, it gives you a mighty shake-up, that's for sure. And a head injury frequently leads to a chronic fatigue syndrome-like illness for a while. And so if you've already got chronic fatigue syndrome and you get a head injury, it's bound to stir it all up, probably, and give you more neurological symptoms. But it doesn't mean to say that healing cannot occur over time, because we know for sure now head injuries, there will be a so-called post-concussion phase, but generally there's a trend towards improvement and recovery for the majority of people, but not for all. It depends on how bad the head injury might have been.
But will that mean that relapses are likely to hit the head each time?
Will relapses hit the head each time? More likely than not, yes, but not necessarily. So chronic fatigue syndrome relapses will often be back to the original type of illness that you had at the beginning. So let's supposing your illness started with a bad attack of flu. Every time you get a relapse, you get, the post-exertional malaise and the tendency for the more generalised symptoms, but often there'll be an emphasis on the flu-like symptoms. So whatever's happened to you in the lead up, that may well be your recurrence. But then if you get something like you have on top of it all, another head injury, it may well just stir it up more. And the head injury becomes a little bit more of a prominent set of symptoms. But because everybody's so different, I wouldn't ever begin to say, well, that's what's going to happen to you. I would say, that might be what happens to you, but it might not. You might make a good recovery. The head injury might be become a non-event. You recover completely from it. It's an unknown. Our bodies are so complicated, we just cannot tell really. Any more queries? Yeah.
I just wanted to ask about exercise, because I've lost 40 kilos and I need to be doing some exercise. But is the key more finding a specific exercise, or is it just a matter of doing something but only for 5 minutes?
Okay.
Because I'm kind of
Get
tried
it
the
right.
hydrotherapy pool, all sorts of things, but nothing.
Well, this lady asked what sort of level of exercise, what kind of exercise, how much should you do, and so on. She's wanting to keep her weight down and perhaps lose more. I think the answer with this illness is, again, everybody's an individual. I don't know if that's mine. Anyway, the majority of people with chronic fatigue syndrome have to learn what they can manage without risking a relapse. And that can be very variable, from the person who could walk maybe 1 minute, 2 minutes to that door and that's it for the day, through to the person who can still maybe play a round of golf or a short game of tennis or something like that. So you work out what you can comfortably manage on your worst day. That's what I would say. You work out what you can manage on your worst day, and that may be just a 5-minute walk, let's say. And that should be your starting point for an exercise plan. And you should say, right, I know I can do 5 minutes quite comfortably without any ill effects either during or after. Therefore, 5 minutes a day is my walk for the next week. And you do 5 minutes a day for a week. If that's been satisfactory and you've had no obvious downside, relapse or anything, maybe then it could be extended the next week to not 15 minutes or 10 minutes even, but to 7 minutes. So you then go a little bit more for the next week. Or if it was swimming, maybe a few more extra strokes or something. And then the following week you maybe go from 7 to 10 minutes, and you build up very, very slowly. If you begin to get worsening symptoms, not so much during but afterwards, you know you've been pushing it too hard. You've got to knock it back a bit. But as long as you can keep within your comfort zone pretty well all the time, and it's almost impossible, but let's say if you try to, there's a much better chance that you'll see yourself progressing very cautiously to improvement. But if you try and, so often people are doing quite nicely and they're sort of coasting along and coming up a little bit, and then they go and play tennis and they crash right down to, well below where they were before. So it's very easy to relapse and be worsening. So you've got to go carefully. Right, we have one. Amitriptyline. Yeah. This lady asks if amitriptyline for sleep is superior to zopiclone, and I would say without doubt yes. Zopiclone is a traditional sleeping pill, so-called benzodiazepine, which is addictive. Not that that's necessarily an issue if you only take it occasionally, but it doesn't give you the type of sleep that you need to get that deep level 4 restoration each night. It just puts you asleep, and it's probably about the same as a strong glass of whiskey. I'm not being flippant, that's true. Amitriptyline or nortriptyline or doxepin, one of the so-called tricyclics, we start with teeny-weeny dose, let's say 5 milligram, might be needing to build it up, but many people stabilise on a teeny dose, and it gives you the swinging levels of sleep, and you gradually begin to wake up feeling more restored and refreshed. So you know then that you're getting restorative sleep and your body is producing all the hormones and chemicals that have a healing effect. A lot of people will say, I took it and, I couldn't cope with it, it was too strong, la la la. And fair enough, we have to acknowledge that for some people it is a hard one to get onto. But amitriptyline, for example, takes probably a week to 10 days to get used to. It needs to be taken about 4 to 5 hours before bedtime because it's very slow to kick in. And if you take it late, you'll be hungover in the morning. But if you can persevere at the smallest possible dose, then there's a very good chance you'll get a restorative sleep established, and it's not addictive in any way. And some people it needs to be put up. We have some people taking 50 milligrams, so.
Can you come off that at some point? When you take
yes. I mean, a lot of people will take it for, say, 3 or 6 months and feel they've improved sufficiently that they don't sense they need it anymore. But I always say to people, wean off slowly to make sure, but also be prepared to go back on it. Yeah, probably nearing the end, aren't we?
If a person has a stroke and then develops CFS afterwards, can those symptoms of the stroke then progress later?
You mean if someone has a stroke and they've already got chronic fatigue?
Before they've got chronic
Oh, I see. So you've had a stroke and then you get maybe a virus and it stirs it all up.
chronic fatigue.
Yeah.
And then the symptoms of stroke come back later, like lack of speech, etc.
Oh, yeah.
Does that?
Well, I think, for anyone, who has more than one thing wrong with them, let's say it's a stroke and chronic fatigue syndrome, or head injury and chronic fatigue syndrome, or whatever, those conditions will sort of aggravate each other. The more things we have wrong with us, the more those things are going to impact on each other and make it harder probably. But it doesn't mean to say that you can't focus on sort of specific treatments for that specific problem. So if you've had, let's say, a stroke, you will need rehabilitation, physical therapy and so on, maybe help with sleep and so on. If you've got chronic fatigue syndrome, again, another set of treatment plan. And those have got to be carefully knitted together to make sure there's safe approaches for each of the conditions.